Αγαπητοί φίλοι, κυρίες και κύριοι, θα μου επιτρέψετε να κάνω την παρουσίαση στα αγγλικά για το φίλο μας, τον ξέρετε όλοι, τον κύριο Τζόρνταν, έρχεται χρόνια εδώ πέρα. Πολλοί από εσάς κάνετε training μαζί του στην Αγγλία ή στην Ελλάδα ή κάπου αλλού. Και θεώρησα ότι θα ήταν καλό να κλείσει την περίοδο αυτή την εκπαιδευτική με μια ομιλία γενικότερου ενδιαφέροντος. So, on behalf of the President of ESO and the Scientific Committee, I would like to welcome Joe Jordan to our hospital today to close the scientific program of this season. Joe is not only my friend, but he's also a friend of this country. He has been recognized among many other achievements for his contribution to the foundation and development of the British Society for Cervical Pathology and Colposcopy, the International Society Federation for Colposcopy and Cervical Pathology, and of course the European Federation for Colposcopy. He played a vital role promoting high standards of care and training in colposcopy among the nations in Europe and indeed the world. This is only a very short summary of his contribution to our specialty, for which I'm sure he wouldn't want me to say more. I thank you for being with us today. The topic of his speech is European Guidelines for Cervical Cancer Screening. Joe?
Thank you, Emmanuel, and thank you all for the opportunity to speak with you today. Why the European Federation for Colposcopy? Well, how do I... Is it this one? Oh, here we go. This is a fact. More women die from cervical cancer than die in childbirth. So if here or in my hospital a woman died in childbirth, we would have a major inquiry and we'd say why, what lessons could be learned, could we have prevented this? And yet, if someone dies from cervical cancer, we say, what a pity, it's inevitable that women will die. And yet, do we really need to have women die? If it's a woman dying in childbirth, we ask the question why. If a woman dies from cervical cancer, we should also ask the question, why? And if we go back, you might find that if she had been screened, if she'd had proper colposcopy, if she'd been advised correctly, then she would not have developed the cancer. So that is the premise upon which the European Federation for Colposcopy was founded. We began in, and I think this is from the same podium here, this picture. The first thought of a European federation began in 1994 in Krakow at one of Professor Basta's courses. And we discussed the way in which we could bring people in Europe together, different countries, different clinicians, different gynecologists, to say we have one objective, to reduce the number of deaths from cancer of the cervix. And Professor Gynaecologist was one of our key helpers when we began this. So that began in 1994, and the Federation actually started officially in 1999, but more of that in a minute. The agenda we gave ourselves, the European Federation, was first to ensure that everyone who performed colposcopy had been trained properly. In my country, in 1999, it was enough for somebody to say, well, I've seen Professor Gynaecologist, I've seen Professor Jordan, I've seen other people do colposcopy, but not properly trained, and everyone had it on their curriculum vitae when they applied for new jobs. So the EFC was formed to ensure that all colposcopists were trained properly, to revise and improve training methods so everyone was trained properly, enhance continuing professional education so that you have your training, but then you need to be updated from time to time, to promote quality assurance. And I introduce a word called clinical governance. I'm sure you may not know the name, but you know what it means. Clinical governance consists of three things. First, we identify the best possible way to do something. Second, we introduce the best possible way to do something. But the third is to audit the fact that we're doing the right thing. So it's all very well to say, I've been on courses and I'm doing things properly, whether it's in obstetrics or gynecology, ophthalmology, orthopedics, but unless you measure your results against someone else, how do we know that we're doing a good practice? So that is quality assurance. To harmonize the clinical guidelines so that we all, as we say, sing from the same hymn sheet. To develop performance indicators so that we can measure the quality of the performance. And finally, to introduce patient-focused quality care standards so that the patients themselves are happy with what we give them. Now, when Emmanuel asked me to talk about this, I thought, well, how shall we approach this? I could show you pictures like this. This is from a woman aged 17. But you would look at this, and I sometimes show this as showing CIN3, high-grade precancerous disease. It has all of the caliber, the qualities of that. It's acetyl-white, it's dense acetyl-white, it has punctation, it's Schiller negative, and yet this woman was aged 17, and that was a perfectly normal cervix. All she had was immature metaplasia. I could show you slides like this. 500,000 new cases of cervix cancer worldwide, and the majority you will see are in sub-Saharan Africa. I could show you this, the incidence of cervical cancer in Europe. You have a very low incidence of cervical cancer here in Greece, but other countries have a very high incidence. And one of the aims of European Federation was to bring together countries which were here in red and help them to move towards the yellow. We could show you how cervical screening takes place in the UK, in Europe. And is there a pointer, Emmanuel? No matter. It's okay. Oh, it's there. Okay. All right. Thank you. And this slide is to show that some countries, as in the yellow, have HPV screening, and other countries have, we're going down to the white, which is here and here, have other types of screening. So there are many types of screening in Europe, but the important thing is that whichever method you use, whether it's Pap testing or whether it's HPV testing, then it needs to be done prospectively. The woman should be called at 20 or 25, depending on what you feel is appropriate, and then brought back again every so often. So we could talk about that. Or I could show you that HPV infection leads to precancerous disease. And by eradicating HPV, we can eradicate cervical cancer. I could show you that by beginning with condyloma or CIN1, which are HPV changes, the majority of these regress due to the immune response of the woman. If it progresses, it could be CIN2 and CIN3. We could discuss cofactors like tobacco, herpes, hormone changes, and so on. But you know all this. I could tell you about screening and secondary prevention, that if you do a screening from the first year and you pick up intraepithelial lesions and remove them, then you don't get cancer. If you don't do anything, then cancer occurs. But again, you know that. So what I thought we would do is to look at this. We know that screening works. This was in the UK, and it ended, this one, in 1995. We introduced cervical screening in 1987, and within the next 10 years, the number of deaths, the incidence of cervical cancer had dropped by 75%. So screening does work. you know that. So I thought it might be more interesting to look at this in a slightly different way, and a little bit of history. Now, those of you who know the works of Virgil know that about 2,060 years ago, he said, "O ubi campi." Now, I'm sure you know what the Latin means, but if not, I'll explain this at the end because it is relevant. He was looking at the past. And I thought that one person who has impressed me over the years was this man called Lawson Tate. He was born in 1845 and he died in 1899 when he was only 54. And the Americans used to refer to him as the father of abdominal surgery. And the reason for mentioning Lawson Tate is because it brings in the question of infection and how infection, later on we know, leads to cervical cancer. In the 14th century, Henri de Monville, a Frenchman, was describing a surgeon. And if you look at this, you'll see, he says, "I do note 4 things most especially that every surgeon ought to have. The first, that he be learned. The second, that he be expert. The third, that he be ingenious. And the fourth, that he be well-mannered." I think we know many surgeons who are learned, expert, and ingenious, but we also know many surgeons who are not necessarily well-mannered. You are. Lawson Tate was learned, as you'll find. He was expert, and he was ingenious. He kept thinking of new things, but he was not a nice man to know. He was not well-mannered. He was born in 1845 in Edinburgh. He went to university when he was only 15 to study the arts. Within 1 year, he moved to medicine. So he started to study medicine when he was only 16, and he qualified as a doctor in 1886 when he was 21. The point about this was his link with Birmingham, where I'm from, and in 1871, he established the first Birmingham hospital for women. Now, we still have a hospital only for women in Birmingham, and it is now the only hospital purely for women in the United Kingdom. There were others. Liverpool had one. That's now merged with the General Hospital. There was the Elizabeth Garrett Anderson Hospital in London, which is now finished and which is merged. So even now, what his idea was that a hospital only for women was a good idea, and it still exists. And that actually was the first one. This terraced house, he bought this house in Birmingham, and this, as you can see, is a very old photograph of the hospital. Now, he made his name. There was an operation which they used to refer to as Tate's operation, which was removing both ovaries. And he said he did this to arrest menstrual hemorrhage due to fibroids, uterine myoma, and for chronic ovaritis, which he meant by chronic infection. It was really of the fallopian tubes, but he thought it was of the ovaries. And this became known as Tate's operation, and he was criticized for removing the ovaries. But as you can imagine, if you had a woman with lots of fibroids, heavy periods, menorrhagia, metrorrhagia, then to remove the ovaries would stop her problem. Now, this is an old photograph. Can you think of what it was like before we had sutures, like catgut or nylon sutures to tie off our pedicles? And what Tate had available to him at that time, this was a clamp which was used by carpenters when they were working with wood. This was to hold the wood steady while they were working on it. And what Tate did, they brought out the ovarian pedicle onto the abdomen, clamped it with this wooden and brass clamp, and after about 10 days, they would remove the clamp and push the ovarian pedicle back into the abdominal cavity and hope that it was good. And of course, a lot of these women developed infection. And then in 1873, he found that if he ligatured the ovarian pedicle instead of clamping, in other words, put a tie around the pedicle instead of that, then this was much better and he could close the abdomen. he looked at hospital mortality. Why do people die when they came to hospital? And he was aware that when women who had puerperal sepsis, or women who developed a problem with childbirth and had to go into hospital, that a large number of these women died from infection because they were in a general hospital. And therefore, this was why he advocated small hospitals. And it was at the same time he introduced his, in 1877, removing both tubes for chronic infection of the pelvis. He described a variotomy. We would say a variotomy is to open an ovarian cyst and to leave it, but by this he meant oophorectomy. He developed this operation of removing the tubes. The first 50 cases he dealt with, the mortality rate of women was 38%. So 1 in 3 of his patients died because of the operation. And then the second 50 cases, and I'll explain what Listerism is in a minute, the mortality was only 60%. And he claimed that this was due not to the increasing skill and experience of him, the surgeon, but to the adoption of simple cleanliness in place of antiseptic methods. You may remember Joseph Lister was a surgeon, a gynaecologist in the UK, who at this time thought that if you used a carbolic spray, he sprayed the operating theatre and the patient and the instruments with carbolic solution, which was antiseptic, then this reduced the infection rate. Tate disagreed with that. He said that the main reason he got better was because he was using a ligature with silk, and he said that his methods were better than Lister's. Now, if we look at what Lister was saying was antisepsis, prevention of infection by spraying the operating theatre with carbolic acid. What Tate did, he said you should clean your hands with soap and water. Now, what a surprise. But if you remember, when you've read about surgery in that time, 150 years ago, it was not common to wash their hands. They operated in their outdoor clothes. They might change their jacket, but might wear an apron to protect themselves. But infection was something which they didn't know very much about. He cleansed the abdomen of the patient with turpentine, which is like petrol, and soap and water. And he poured boiling water on the instruments to sterilize them. And the sponges which he used, instead of swabs, washed them with soda, which is carbolic soda, and carbolic lotion. In other words, that would kill off any bacteria. And he used dry dressings. So he was aware that infection was a problem. He first described the removal of the fallopian tube for a ruptured tubal pregnancy, an ectopic pregnancy, which was quite a major breakthrough. And then this was his first attempt at what we now call clinical governance. He audited the first 1,000 cases of laparotomy. And he used to say, if there is something wrong in the abdomen and you don't know what it is, have a look, open, which is what he did. And he described 1,000 cases. And that, as far as I'm aware, is the first time anyone made an audit of such a large number of cases having a surgical procedure. That was him just before he died, and he died from renal calculi in 1899. So that was Lawson Tate, and how infection did affect obstetrics and gynecology. Now, it was often said that there were 3 outstanding surgeons in the 1800s. James Y. Simpson, who invented chloroform, and you may remember that Queen Victoria popularized the use of chloroform in childbirth because she was given chloroform to assist with labor pains. There was Joseph Lister, who introduced antisepsis, and Tate referred to as the father of abdominal surgery purely because he did so much and because he said, if you don't know what's going on, for goodness sake, open. Now that's in the 1800s. Now we leap forward to something else which is actually very relevant to cervical cancer. And this was in 1966 in New Zealand. Professor Herbert Green postulated that women with carcinoma in situ, we now call CIN3, were at no greater risk of developing cancer than those who had a perfectly normal cervix. And he said that we should leave them alone. If you diagnose CIN3 or carcinoma in situ, do nothing. We will just watch, and they might get cancer, but no more often than women who had a perfectly normal cervix. And that, of course, was contrary to world opinion, even in those days. And the fact in 1966 was that world opinion said that cervical cancer was preceded by a precancerous state. Carcinoma in situ was then, now CIN3. And the debate was not about whether it happened. The debate was purely about what proportion of women with CIN went on to develop cancer and over what period of time. So that was world opinion. So what happened in the New Zealand Women's Hospital in Auckland? Well, in June 1966, the medical committee met, and Green proposed that, and these were his words, and I was involved with this at a later stage, and I've read the original documents, and this is what it said: the time has now come to diagnose and treat by lesser procedures than hitherto a selected group of patients with positive smears. In other words, people with CIN3, leave them. What he did, cytology was positive, colposcopy was positive, a biopsy confirmed the presence of CIN3, and he decided, we'll leave well alone, we won't treat. And they were followed up. And the issue was that women under 35 with proven CIN3 should be left without treatment and followed regularly, and if they developed cancer, they could be treated. Now that might seem absurd to us today, but in fact that is what he proposed, and that is what was agreed. And the criticisms of his proposal were this was a trial, but he didn't tell his colleagues when it would end or how he would measure the success or failure. In other words, there was no audit, so he did not know whether he was right or whether he was wrong. And certainly it was contrary to world opinion in 1966. It was presented to the other gynecologists in the hospital, in the medical committee, but none of them were experts in the field. And in fact, in 1966, and that was the year I went to Birmingham to learn colposcopy and to see how we could treat people with CIN3. Most people did not perform colposcopy. It was very uncommon. And the standard treatment for CIN3 in 1966 was hysterectomy. So you can understand why Green said, if we can avoid a hysterectomy on these young women, then we should do so. But it was the way that he went about it which was at fault. And he didn't discuss this with his colleagues. He told them what he felt they should do. And had they known what the current state of affairs was in the world in 1966, it's unlikely that it would have been approved. Now, we'd look at ethical approval. If any of us today wish to do a trial or introduce a clinical trial on the use of drugs or surgery, we have to go through a clinical ethics committee. There was none in those days, and therefore it was up to his colleagues, the hospital committee, to decide. And over the next few years, it became apparent that some of these women did develop cervical cancer and some died. But Green refused to accept that he was wrong. In 1974, he published a paper which he said showed that he was correct. It was a follow-up of 8 years of women who'd been left without treatment. And some of them developed cancer, and some, the majority, did not. But the way he analyzed the paper was such that he could have said in 1974, hands up, I was wrong. Instead of which, he used the evidence in such a way to prove that he was right. And this, to me, was a classic example of someone who had a conclusion and wanted to use their trial, wanted to use their clinical trial, use the patients to prove that they were right. Whereas, of course, the question he should have asked was, do they develop cancer more often than the normal population? And if so, I need to know. And if he'd asked that question and used his experiment to produce the answer, he would have known in 1974. But he chose to ignore it. And it came to light in 1987 by a newspaper. It was a journalist who heard about this, and she did some investigations, spoke to some of the women who'd been on this trial, some of who'd developed cancer, families of some who'd already died, and she reported this as an unfortunate experiment. As a result of this, the New Zealand government set up an inquiry led by a judge. The judge's name was Judge Cartwright. That was in 1988, and I know because I went down to that. And it was curious because this went on, instead of just for 4 weeks, which they thought it would be, it went on for 7 months before they found a conclusion. And what was incredible was that the newspapers and the television people were there at the hearing, at the inquiry. And on the national news in the evening, if there was anything which was new or worthy of being reported, then it would appear on national television. And that was the Cartwright inquiry. And I won't tell you all of her conclusions, but she said there was a major research trial at National Women's Hospital, although it wasn't called a trial. But this might seem strange to you that she should use this conclusion. What she said was that gynecologists, administrators, and health professionals should listen to their patients. And how often do we hear patients groups say, why don't you listen to me? Why don't you listen to the patients? Instead of just telling them what you think they should have. That they should communicate with them. In other words, a consultation is two-way. Patient talks to you, you talk to the patient, and between you, you agree on a way forward. Green didn't do that. He gave them no opportunity. We have a responsibility to offer the best health care within our resources and confront colleagues if standards slip. And there's an expression which we have, I don't know, whistleblowing? Do you have an expression in Greek for whistleblower? Well, you know what it is. If you think there's something wrong, you should report it. And doctors have been guilty, I think, in many occasions in the past of not reporting colleagues if they should have done. And if these things do not happen, then the kind of events which occurred in New Zealand during this inquiry may well occur again. So that was that. And shortly after that, the New Zealand General Medical Council held a hearing. Professor Green himself didn't appear because he was thought medically unfit. Bonham, he was the professor in 1966 who should have known, and he was the head of the department, but he didn't do anything about this. In other words, Bonham knew that there was a problem with this trial, and it wasn't reported, and he was found guilty of serious professional misconduct. So the point of that story is twofold. First, it confirms that CIN3 does progress to cervical cancer, and if we identify and remove CIN3 from the population, then that woman will not die from cervical cancer. The other thing, of course, is that if things are going wrong and we know that a colleague is misbehaving or performing badly, then we have a responsibility to discuss this. So we come back to the European Federation for Colposcopy. And although the idea was formed first in 1994, the first European colposcopy meeting was in Dublin in 1998, and then the federation was formed in 1999. And the first Congress, we have a European Congress every 3 years, and the first one was in Rhodos in 2001, organized by Professor Gynaecologist. We asked him to become president of EFC in 2001, and he said, no, you carry on doing it. But he then actually became president in 2004. So apart from myself, you, sir, were the next president of EFC. And we began training courses throughout Europe and Turin. The satellite meeting, once every year, we have a meeting, usually in Brussels, in which we invite one representative from every country affiliated to EFC. We pay their expenses, and we say, come and meet with everybody from Europe. And there are 34 countries in and around Europe now affiliated to the European Federation. So it's going well. We're very happy with that. We appreciate that it's important to train the trainers, that people who train in colposcopy, how do they know that they're good at training? How do we know that they're good trainers? The first advanced course was in Helsinki earlier this year, and the first regional meeting was in Riga, which was all of the Baltic countries. That was Sweden, Finland, Latvia, Estonia, Lithuania, all met together. So the training program is going well. And we have member societies from Iceland, and we go right through to Israel as also a member country. The European Union commissioned a group to produce European guidelines for quality assurance in cervical cancer screening, and this published its second edition in 2008. And one of the most important things about that was that there should be prospective screening. In other words, from the age of whatever you feel is appropriate, say 25, then every woman should be given an invitation to have a cervical smear test. And this covered pathology, it covered the administration. But the other major important thing was that unless the government of the country, unless the government of any individual country is in favor of screening, then it can't happen. We wanted to improve colposcopy as being the key, and the colposcopists are the people who could drive this agenda forward. And the setting was colposcopy rooms, and how do you have a proper colposcopy clinic, training of colposcopists and nurses, education. But again, we come back to quality assurance. How do we know that we're giving the best possible standard? And the steps in quality of the EFC are education, training, and practice. It applies to everything in medicine. It applies to other disciplines, other professions, law, for example, that if you educate people, then they have to be trained, and then you have to ensure that they do good practice. The European Board and College of Obstetrics and Gynaecology has been set up by the European Commission to oversee training in obstetrics and gynaecology throughout Europe. And here you see that in the recommendations which they make on training in gynaecology, one of them is that all colposcopists should have had formal training and be recognized or certified as suitable to practice colposcopy. All European training programs should comply with European Federation for Colposcopy training standards. So that's EBCOG, and that is part of their training manual for young doctors. What has EFC done for education? Developed the core curriculum, agreed standards for basic and advanced training courses, such as you have here, EFC recognition of courses, that if someone wants to hold a course, we would say, if you submit the details of your course, if it's suitable and we feel it's appropriate, then you can put on your course that this has EFC recognition. Provision of targeted courses in different countries and different centers, and continued professional development of the teachers. The training program structure, there should be uniform. There should be a caseload. In other words, if someone is seeing only one colposcopy case each month, is that enough to allow you to retain your competence and to say that you're a skilled and a proper person to deal with this? And the way that many countries now get around this is to say that instead of every gynecologist having a colposcope and doing colposcopy as a screening procedure, as happens in some countries, and in Germany, for example, one of the major problems we've had is to say there is no need to screen by colposcopy every year. Do your cytology screening or HPV screening. And yet, I can understand why gynecologists, say in Germany, will say, but I do not operate on cancer. I don't do operations for stress incontinence of urine. I do an annual checkup for my patients, and that includes colposcopy, for which I get paid. So it's part of the culture of many countries. But we would say, and the European guidelines said that there was no indication to do routine colposcopy. But that was to do with caseload, that every unit should see a reasonable number. And what many countries are doing now is to say, okay, it is not necessary for every gynecologist to do colposcopy. But if you have a group of gynecologists, have one or two who see most of the abnormal cases. The developments, international collaboration with the International Federation for Colposcopy, with various countries and with EPCOG. The format and scope of meetings and courses has been standardized. New technologies, as they're introduced, should be made available. And there is a constant review of training methods. Quality assurance, this question of how do we know that we're doing a good job? Well, first, the guidelines for how you do things, collaboration with ESCO, the European Society for Gynecological Oncology, performance standards, individual performance profiling. In other words, we look at the profile of an individual colposcopist and say, how many cases are you dealing with? How many were high-grade disease? If you operated for CIN3, how many patients had persistent or recurrent disease? In 4 or 5 years, how many of your patients can be told that they have no further disease? In other words, it's back to the question of audit and how do we know that we're doing a good standard of practice unless we audit our work. Same with individual performance profiling and the quality of care standards. And finally, I think we have to ask the question, just as we began, if a woman dies in childbirth, there is an inquiry, and every aspect of the case is looked at. Perhaps we should do the same with every woman who dies from cervical cancer and ask, could we have done any more? Could we have persuaded our government to introduce a program whereby the woman is called at age, say, 25 and has regular screening? And there's also a question of how do we screen? And almost every country now which is introducing a planned screening program will opt for HPV testing. And yet I was at a national meeting only 2, 3, perhaps 4 years ago with Emmanuel, and the government representative agreed that they would introduce a planned population screening program, but based on cytology, whereas every other country which was introducing it was basing on HPV. So the way forward is to have regular planned population-based screening, HPV vaccination for girls and boys. In the UK, for example, when the program was introduced, it was only for girls, and that was purely based on the amount of money they had to spend. This year, it is being extended to involve boys. So girls at age 12 are invited for screening, for vaccination, and now, in the future, boys age 12 will be invited for vaccination too. HPV screening seems to be the way forward. I could talk about visual inspection with acetic acid by taking photographs and sending them on to someone else to look at, but we're not talking about that here. What we're looking at is how do we assess the woman. Is this woman at risk? If she's got HPV, then she is at risk, but most women with HPV, and most young women will have HPV if they're sexually active, that most HPV is eliminated. And one of the major steps which has occurred in Europe is to say, if we have a young woman, for example, age 22 or 23, with low-grade cytology, low-grade colposcopy, biopsy, perhaps CIN1 or CIN2, it's not necessary to treat that woman. We can wait. And one of the big things that happened in the UK was when we increased the age at which we began screening from 20 to 25, is because thousands of young women aged 20 to 25 had mild abnormalities on cytology. Colposcopy showed an abnormality. You could show the woman this on a screen if you had a screen, and you'd say, you're at risk of cancer, therefore we should remove this. And of course, you all know that by doing excision of CIN at an early age affects the obstetric future, that premature delivery, premature birth is more common. And therefore, HPV screening, that actually may be the way forward. Most countries now are moving to that if they're not already there. And it may be that with HPV screening, we can start at the age of 30 rather than 25 or 20. Certainly, there is no indication to do screening on 17 or 18-year-old women. And therefore, HPV screening will reduce the number of times a woman comes for testing. And it may be that she can self-test. There are self-tests available now, which you can give to a woman, and she can put a specimen tube into the vagina, put it into an envelope, and then send it off to the laboratory without having to have a clinical examination. And of course, we have finally the fact that HPV therapeutic vaccines are now being trialed. And I would just end by saying that the next triennial meeting of EFC will be in Rome at the end of September next year. So you put that in your diary. It'd be nice. Rome at the end of September is really very nice. And the translation of O Ubi Campi from Virgil is, where have the fields gone? When he was an older man, he went back to the village of his youth in northern Italy. And he looked around and he saw the changes which had occurred in his village. And instead of saying, oh my God, what's happened? He said, where have the fields gone? And the fields, new houses, new everything. That was the message of that. And my message from this, and why I use this, is that things do change. And in my lifetime as a medical director of my own hospital, one of the most difficult things I had to deal with were older colleagues of my own age group saying, you're telling me we should consider doing it this way. I've done it this way for 20 years or 30 years. Are you telling me I was wrong? The answer is no. We're just saying there is a better way. And all I'm saying is we should always keep an open mind. And at the end of the day, the patient is our responsibility. And I'd like to think that every woman who dies in childbirth, there is often a way in which that could have been avoided. And it's the same with cervical cancer. And I'd end by saying, Emmanuel, thank you for your support. Thank you for being such a good friend. And thank you all.